since basically all we're going to talk about is the law. In order to understand the waiver that allows you to prescribe buprenorphine and other medications under Data 2000, we have to go back to the Controlled Substances Act of 1972, which I think no one in the entire medical community remembers but me. This was the law that gave us all of these schedules for the various medications that we do prescribe. It gave us schedules 1 through 5, 1 of course being not appropriate for medical use, and then 2, 3, 4, and 5, the medications that have some abuse liability and decrease as the number of the schedule increases, which is weird, but that's okay. Congress does what they want. The Controlled Substances Act of 1972 is the overarching legislation covering the appropriate prescribing and dispensing of controlled substances. It's the legislation that mandated that methadone be only used in OTPs. Prior to 1972, between 1965 and 1972, methadone could be prescribed by physicians. This put methadone into specific clinics, OTPs, opiate treatment programs. And you had to be registered with the DEA, with the FDA, and your state, and for all I know, 9,000 other things. But it made it really difficult for a lot of people to be able to access methadone because it was so hard to get an OTP in a lot of areas, particularly rural areas, because you simply didn't have the number of patients to justify the amount of paperwork that went into doing a methadone clinic. And prior to 2000, it forbid doctors from prescribing opiates to patients suspected or known to have a substance use disorder. So from 1972 to 2000, it was illegal for us to prescribe to a patient that we knew or should have known to be addicted to opiates. Data 2000, which is the Drug Abuse Treatment Act of 2000, and later CARA, which is the Comprehensive Addiction Recovery Act of 2016, amended the legislation, amended the Controlled Substances Act of 1972. When you're thinking about treating opiate use disorder and what's legal and what's not, methadone is only legal within OTP situations, within an opioid treatment program. It's legislated under the Controlled Substances Act of 1942, and the specific rules for it are in 42 CFR Part 8. Buprenorphine can be used in office-based practices under the exceptions listed in Data 2000 and its amendments, and it's been amended a couple of times, and then CARA, which was approved in 2016. Naltrexone has no legal restrictions. So if you're using naltrexone or by oral route or by the injection route with the naltrexone extended release, there are no legal restrictions on its use. If you're using buprenorphine in an opiate treatment program, then it comes under the same legislation and guidance as methadone does, and it's in 42 CFR. There are some exceptions within 42 CFR now for buprenorphine in OTPs, but since Wyoming doesn't have any OTPs, we're not going to spend any time on that. So what we're basically going to talk about is buprenorphine in office-based practices, which doesn't necessarily mean office because a lot of clinics use it and they come under the exception listed in Data 2000 and CARA. So that's really what we're going to be talking about. And as I said, naltrexone has no legal restrictions, so you don't need a waiver. So what is the Drug Addiction Treatment Act of 2000, otherwise known affectionately as Data 2000? It is an amendment, as I said, to the Controlled Substances Act. It allows practitioners to prescribe FDA-approved narcotic drugs. I love the way Congress puts that. In Schedules 3, 4, and 5, or combinations of such drugs for the maintenance or detoxification treatment of opioid use disorder. So basically what it means is you can prescribe some medications, but not things like methadone. Methadone's a Schedule II, so it's not covered under Data 2000. It does not permit any limitations on the quantities of drugs that may be provided for unsupervised use unless the drugs have been subjected to an adverse determination. They have not. But the drugs and the practitioner have to meet certain requirements under Data 2000. The practitioner requirements are that you have to be a qualifying physician. We'll get to what that means in just a second. You have to have the capacity to refer patients for appropriate counseling and ancillary services. This was a big point of contention because there were some people who said, well, shouldn't the physician have to provide it? It was like, if you're talking about a private practice person or an internist or something like that, they may not have counselors available, but they have to be able to refer for the appropriate counseling and the ancillary services that come along with it. And then the initial way that Data 2000 was written, you could have no more than 30 patients. That has been amended to that you can have no more than 30 patients, and we can talk about what the 30 patient limit means, for the first year. And then after that, you can request approval to treat up to 100 patients. And to move from 30 patients to 100 patients requires about 15 seconds on the internet with SAMHSA, just saying you want to go up. But again, that's after the first year. If anybody has any questions, please don't hesitate to interrupt. So what is a qualifying physician? A qualifying physician is someone who is board certified in addiction medicine or in addiction psychiatry. And that is by APBN for addiction medicine, and it's now the American Board of Preventive Medicine for ABAM. ABAM, the American Board of Addiction Medicine, has now come under the auspices of the American Board of Preventive Medicine. Or you need to be certified in addiction medicine by the Osteopathic Academy. You can have been an investigator in buprenorphine clinical trials leading to its FDA approval. Or, and this is what most people do, completed 8 hours of training provided by one of the following organizations. And basically, AAAP, which is the American Academy of Addiction Psychiatry, APA, and the American Society of Addiction Medicine provide most of the trainings that are available. The state medical licensing board can chime in with additional training or experience, but to date, none have. And the Secretary of Health and Human Services has not seemed to have any interest in establishing other criteria. So it's one of the top 5 there that you have to do. What most people do is either take the 8 hours online or go to a live 8-hour training and get their 8 hours in, and then you are a qualifying physician. And then you have to notify the Secretary of Health and Human Services online. Actually, the Secretary could care less. You notify SAMHSA, and actually you notify the drug abuse treatment area of SAMHSA. You have to put your name in, your DEA registration, category 1 through 7 or 1 through 5, and certify the intention to comply with the law. And you have to do it online. You used to be able to do it by fax or mail or online or whatever, but now it has to be done online. It literally takes about 60 seconds. I helped somebody fill it out one time because they kept saying, I keep forgetting to do it. I said, well, pull up the website and we'll do it right now. And we got finished. She goes, that's all? I said, that's it. They kind of made it dummy proof, which is sometimes a really good thing. The other thing that has to be approved under Data 2000 is the drug, the medication. Narcotic here is used in the legal sense of the Controlled Substances Act. And the legal sense of the term narcotic drug makes no sense because it not only includes all opioid products, but other medications such as cocaine, sedatives, you name it, They just lump them under narcotics, which is why when you hear that the police made a narcotic bust, it can be anything from marijuana to fentanyl, or heroin or whatever, because they consider anything that has abuse potential to be a narcotic. But the medication has to be approved by the FDA for use in maintenance or detoxification treatment of opioid use disorder. It has to be Schedule 3, 4, or 5, and it can be drugs or combinations of drugs. Currently, buprenorphine is the only medication that is approved, and that is buprenorphine and buprenorphine naloxone are both approved under Data 2000 as qualifying drugs for this exception. Some of the medications that are not approved are methadone, it's a Schedule 2. Buprenorphine immediately release injectable, Buprenex. It is approved for pain management, not for the treatment of substance use disorders. The sublingual film for pain, which the trade name is Belbuca, which is also approved for pain, but not for the treatment of opioid use disorder. The transdermal buprenorphine, Butrans, again, is approved for pain, but not for substance use disorders. Tramadol is now a scheduled medication, so it cannot be used to treat opioid use disorder. And basically any medication not on the approved list. And since the approved list is buprenorphine and buprenorphine naloxone, the list isn't very long at the moment. We're rather hoping that some medications will come along to be approved and put on this list. But the way that they have been handling newer formulations of buprenorphine, they've been getting them approved for pain and not for opioid use disorder, except for 2 newer formulations of buprenorphine that are approved for the treatment of opioid use disorder. And one is a 6-month implant and one is a long-acting injectable that lasts for a month. And the other thing that you need to think about is Data 2000 and CARA 2016 only apply to scheduled medications. Sometimes the DEA seems to forget this. And they bring up things like naltrexone and that sort of thing. And they're just sitting there going, you don't have any authority over naltrexone. So they apply only to scheduled medications. Use of buprenorphine in hospital settings. This is an issue that always comes up. And so I figured I might as well put it in here. If the patient is in the hospital for reasons other than substance use disorder, buprenorphine, or in fact methadone, may be ordered by any provider for medical stabilization for the duration of the hospitalization. You do not need a waiver. You do not need permission from anybody to prescribe methadone if that's what you think is more appropriate for the patient. Or in fact, and I did this one time, I had a patient, we did get questioned. It was perfectly legit the way that we did it, but I actually had to have a patient one time on 20 milligrams an hour of morphine because he was so massively addicted to opiates when he came in. And then we moved him to methadone and then into treatment. But the issue is if the patient is not going to continue with opioid use disorder treatment after their hospitalization, you really need to taper the patient off of buprenorphine, or if you're using methadone, appropriately before discharge. You can't just tell a person, well, you're only on 8 milligrams of buprenorphine, so just, you'll be fine, bye. There will be a withdrawal syndrome. Buprenorphine is an opioid. It's a partial agonist, but it's an opioid, and the patient will go into withdrawal. And it is not appropriate to just send the patient out without any referral for treatment or anything else and just say, have a good life. So you need to do that taper while they're in the hospital. Or if the patient is to be continued on opioid use treatment after discharge from the hospital, the arrangements for that treatment with an OTP or more likely in Wyoming, a data waiver practitioner must be done prior to discharge. You can't just hand them a list and say, well, these people actually have waivers for buprenorphine, you might call them. Somebody needs social services, whatever, needs to call and get that patient an intake so that they can be managed appropriately once they're discharged from the hospital. What about medical emergencies? If the person is seen in the emergency room and wants treatment for opioid use disorder, but no OTP or data waiver practitioner is available, the emergency practitioner can invoke the 72-hour or 3-day rule. And I've gotten plenty of questions about this, which is why I put it in here too. In order to use the 72-hour or the 3-day rule, you do not have to have a data waiver under a waiver under Data 2000. The 3-day rule, according to the DEA, is an exception to the Controlled Substances Act of 1972, to the registration requirement, otherwise known as your DEA number. And it allows a practitioner who is not separately registered as a narcotic treatment program or as a certified data waiver practitioner to administer but not prescribe narcotic drugs to a patient for the purpose of relieving acute withdrawal symptoms while arranging for the patient's referral for treatment under the following conditions. You can't give them more than 1 day's medication, and it has to be administered or given to the patient at one time. You cannot go past the 72 hours, and it cannot be renewed. So if you have the patient in the emergency room, they can come back for days 2 and 3. But by that time, you need to have somebody that they can get into treatment with who has a data waiver, or who, I understand that there's a OTP up someplace in Montana, and if they're close to that, that would be an option for them too. And I know that there are OTPs in Colorado, and if they're in the southern part of the state, one of those might be appropriate. But you can't give, one of the things that I hear people want to do is give them a prescription for a 3-day taper. You can't do that. They have to come in every day, which is, I know, a pain. CARA, which is the Comprehensive Addiction Recovery Act of 2016, was signed into law on 7/22 of 2016, and it revises some of the regulations. And it says that after a year of prescribing for up to 100 patients, if you meet certain other requirements, you can request approval to treat up to 275 patients. But in order to do that, you have to be board certified in addiction medicine or addiction psychiatry, or you have to be practicing in a qualified practice setting. We'll get into what that is. And there are annual reporting requirements that I'm not going to get into because they take up about 3 slides. The other thing that CARA 2016 did was expand prescribing privileges to nurse practitioners and physician's assistants for at least 5 years. The law says until October 1st of 2021, but in all probability, they will simply extend it and take that limitation off. But for whatever reason, they decided that NPs and PAs must complete 24 hours of training. So they have to have the 8-hour training to get the waiver, and they have to have 16 more hours of training in substance use to be eligible for the waiver to prescribe. And they have to be supervised by or work in collaboration with a qualifying physician if that's required by state law. A lot of places do require that an NP or a PA work in collaboration with a physician and under certain standards that the NP or the PA and the physician have agreed on. And in that case, the physician needs to be a data waivered physician for the NP or the PA to work with them. They don't have to be in the same location, but they have to have that supervision or collaboration contract in place. If you're going for the qualified practice setting, you have to provide 24-hour emergency coverage. You have to have case management and related services. You have to use an electronic medical record. It needs to be registered with the state prescription monitoring program, which I know everybody in Wyoming is anyway, so that's not a big issue. And you have to accept third-party payment for services. One of the big things that we have in various areas of the country is buprenorphine providers who only take cash. So they would never be eligible for this exception under CARA 2016. And the DEA is really looking at a lot of those programs. So, I mean, the way that it was conceived was that this would be regular medical practice in a regular medical or psychiatric office under regular conditions, which means you accept insurance. But some people decided it was a good way to make some quick money. So you do have to accept third-party payments. And as I said, the other thing is it has specified new standards of care. For instance, you have to have a board-certified practitioner. You have to have access to behavioral health services. You have to follow evidence-based treatment guidelines. You have to have individualized treatment plans and a diversion control plan. And again, you have to use the state prescription monitoring program and annual reporting requirements, which is a whole bunch of statistical stuff that they want to know. So how do you obtain the waiver? Complete the education, notify SAMHSA, and within 45 days, if they don't tell you no, you are approved. And you will receive a new DEA license with what we call the X number. Your license will then have your normal DEA number, for instance, AB 1234567. And underneath it, it will have XB 1234567. The exact same thing, only the first the first alpha digit is changed to an X. You now have the waiver. It's not that hard to get one. You don't have to pay for it. It's one and done. Once you have it, you're good. You don't have to take training again every 6 years or 3 years or make up a number however you want to. That's all you have to do. Complete the education, notify SAMHSA, you're in. When you write a prescription for buprenorphine, you put both your regular DEA number and your X number on the prescription. For any other medication that you write that you need a DEA number for, you put only your regular DEA number. If you are using buprenorphine for pain, you do not use the X number. You use your regular DEA number. But that's really all the waiver is that yes, you completed the education, yes, you notified SAMHSA that you're going to be doing this, you're done. And the law says that they have only 45 days to give you an answer. So who needs the waiver? Any appropriate practitioner who wants to prescribe medication under DATA 2000 or CARA 2016. Physicians, nurse practitioners, physician's assistants. So anybody who wants to prescribe buprenorphine to treat opiate dependence, and that is for either detoxification or maintenance. That's who needs the waiver. And that's it. It's not difficult. It's just something that they decided that they had to have some oversight on, rather than just putting it out there and letting everybody prescribe like they did in France. So questions, please.